commonly in the brain, astrocytoma may be indolent, may be aggressive. According to the classification or the grading, the tumor grade, it will derive prognosis and clinical decision making. This image of low-grade astrocytoma. The enhancement go regular. It may be encapsulated, compressing, non-infiltrating, with no areas of hemorrhage or necrosis. Now we can go with oligodendroglioma. This is a relatively rare type of the glioma. The tumor develops from a specific type of the glial cells, oligodendrocyte. This is account to 10% of all primary intracranial tumor and 5 to 25% of the gliomas. Most of oligodendroglioma are slowly growing, benign, non-encapsulated, infiltrated tumor of the white matter, which are usually located paraventricular. Small lesion. Actually, this is rare tumor. It may go paraventricular beside the ventricle here, beside the third ventricle. Oligodendroglioma, 85% of tumor supratentorial, affecting mostly the frontal lobe. The tumor is characterized by the formation of foci of cystic degeneration and calcification, and it manifests also with cellular atypia, occurrence of mitosis in the tumor, and proliferation of vascular endothelium. On molecular biology, oligodendroglioma may go with IDH mutation and 1p19q deletion. It can go with the grade 2 diffuse, grade 3 anaplastic, and grade 3 with the highest grade of oligodendroglioma. This is to confirm oligodendroglioma are rare tumor. It go paraventricular. It go with low grade, grade 2 in diffuse, grade 3 anaplastic, and grade 3, which is the highest grade of the oligodendroglioma. It has cellular atypia and cystic degeneration and calcification also. By histopathology, this is moderately cellular, diffuse infiltrating neoplasm, mild to moderate nuclear atypia around the nuclei with speckled chromatin. Also, it has calcification, perineuronal cytosis. This cytosis means it has certain feature around the vessels or nerves. It goes like some halos, around the vessels, surrounding the vessels. It go with more accumulation of the cells surrounding. This is a feature of the oligodendroglioma. Anaplastic feature of necrosis and vascular proliferation may be seen in WHO grade 3 tumor. Thus, moderately cellular, diffuse, infiltrating with perivascular or perineuronal cytosis. This is a feature of the oligodendroglioma. Now the glioblastoma or the glioblastoma multiforme, which is the high malignant form of the gliomas and the most common primary adult malignant tumor, accounting 20% of all primary brain neoplasm are glioblastoma multiforme. Glioblastoma is the highest grade. Actually, it is grade 4, associated with high mortality, greater than 90% at 5 years. And the median survival of the patient about 1 year. This means if you have 100 patients of glioblastoma multiforme, 90% or 90 of them will be died within 5 years. Prognosis for this tumor is the extreme worst. This tumor is critical. Actually, we go for immediate intervention once diagnosed GBM. In histopathology, It's a hypercellular infiltrative lesion with variable morphology. It may go with more infiltration, and difficult to be differentiated in the frozen section. If we take a frozen section from inside the operation during surgery or rapidly, it may interrupt neuron. But the highly malignant feature appear in the GBM at the nuclear hypochromatism, mitotic activity, necrosis, and microvascular proliferation. Microvascular proliferation increase in the microvessels inside with more or less divisions and cellular etapia, high division, high mitotic rate, necrosis. About medulloblastoma. Originally, it was classified as a glioma. Medulloblastoma is referred to now as a primitive neuroectodermal tumor. This is part of the embryological remnant or embryological beginning of the neuroectoderm. And this tumor accounts about 7 to 8% of all intracranial tumor and 30% of pediatric brain tumor. Medulloblastoma is the most common malignant pediatric tumor in the central nervous system. It accounts for nearly 20% of all childhood brain cancer, 40% of all childhood tumor in the posterior fossa. This set of tumor considered the most common brain malignancy among pediatric population. Let me ask you now, the most common tumor for the adult actually is the metastasis. And actually it go multiple equal metastasis, secondaries from elsewhere in the body, while medulloblastoma is the most common malignant pediatric tumor in the central nervous system. Medulloblastoma by histology is a small round cell tumor, mild to moderate nuclear pleomorphism with high mitotic count. It has very specific characteristic feature of Homer-right rosette with meshwork of fiber at the center. And now, let's speaking about ependymoma. This group of neoplasms include the following tumor category: subependymoma, WHO grade 1, myxopapillary ependymoma, which is also WHO grade 1, ependymoma, WHO grade 2, and anaplastic ependymoma, WHO grade 3. It is microbiologically fusion positive. This is newly recognized entity codified. This tumor includes the majority of supratentorial ependymoma occurring in children and young adults. To see the features of the ependymoma by histology has characteristic perivascular pseudorosette, very perivascular pseudorosette, non-palisading necrosis, area of cystic or myxoid degeneration and calcification, degenerative etapia, neuronal differentiation, and rarely metaplastic element. Thus, the pseudorosette is a characteristic feature. Do you remember other rosettes, medulloblastoma? And here in ependymoma, we have also perivascular rosette. Subtypes of different morphology according to the grading of the tumor. Molecular diagnosis of the glioma by the tumor grades. We have